welcome you on behalf of UCSF Global Health Economics Consortium, and I hope that today you get your geek on. That's the Ghecon thing, yeah.
Really, what we've generated is more conundrums than answers at this point, to helping us develop hypotheses about how to go forward. So in this first phase of research, we found essentially that male obesity and female smoking are both unusually low in international comparisons related to something like the US, and they can statistically account for the Costa Rican mortality advantage at older ages. So we can ask, well, why do the low SES in Costa Rica have lower cardiovascular risk? Well, we can talk about healthcare access being good, but we know that healthcare access doesn't affect many of the risk factors underlying prevalence, and it certainly didn't help with hypertension. And so people turn again to this upstream social structure and safety net. I would argue that probably diet is one of the most important things that's going on here. The nutritional transition just hasn't fully reached the low SES populations. And so this is one of the things that we really want to start getting into, is the economic factors underlying this nutritional transition, which I think is going to dovetail really nicely with our upcoming talks.
I'll be talking about Berkeley specifically, which was the first city in the nation to pass a tax. But we found that overall, the prevalence of sugar-sweetened beverage consumption declined by 21% in Berkeley, and it increased slightly by 4% in San Francisco and Oakland, the comparison cities. And if we look at the rest of the beverages that we asked about, we can see that there was actually a significant decline, a significant difference in the direction of trend for regular soda consumption, sports drinks, and water. Now, there's a huge increase in water consumption in Berkeley of 63%.
So the tax, the SSB tax in Mexico, very similar to the one implemented in Berkeley, except that in this case it was implemented in the whole country in January 2014. It's also an excise tax of 1 peso per liter of SSBs. This, if passed through, translates into about 10% increase in price to all non-alcoholic beverages with added sugar. So what you see here is the behavior of purchases before the tax. So this is a timeline. This is when the tax passed. And this is how purchases behave before the tax. And then so what we see here is the model counterfactual. So the red line is what would have happened in absence of the tax, model based on previous behavior. And then the red line is what actually happened. And what you see here is a different difference in terms of purchases of tax beverages and an increase in non-tax beverages. And this translates roughly in a 6% decline in purchases of tax beverages in the same year the tax was introduced in 2014. Now, another group of colleagues took these results and say what would be the results in over 10 years in terms of health. And so what they model, actually using this cardiovascular disease model developed here at UCSF, and they look in this paper at cases of diabetes prevented by this reduction of 10% increase, strokes, myocardial infarctions, deaths, savings. So significant impacts on health.
I'm going to talk about the mental, neurological, and substance abuse, or MNS disorders. The MNS conditions have a massive disease burden, and mostly that's due to disability, although, as I said, we may be underestimating the mortality burden somewhat. There are efficient and affordable interventions for most MNS conditions, but there are some challenges beyond the economics. Stigma is high and awareness is low concerning treatment options, so it's a little harder to get people into treatment. Similarly, care capacity to deliver quality treatment is limited, especially in primary care settings. And for some areas, there are limited effective interventions, in particular dementia. So far in low and middle income settings, there's not much that we know works. By the way, dementia is definitely prevented by the same kinds of interventions that will prevent cardiovascular disease and so on. So there's a synergy there. But in terms of interventions specifically for dementia, not much yet. and likewise for some addictions, not many options. In my opinion, as a little bit new to the MNS area, there's ample justification to expand MNS funding and capacity.
There are many purposes of models, as I've already said, but the orientation that PAHO has, that WHO has, that the UN Interagency Task Force has, and these are the organizations that I'm working most closely with right now, and it is very much not from I want to get a really cool technical model and know what it's going to tell me about what to do. It's more, I want something that countries can understand, that can use the limited data, the imperfect data that we have available, that can be improved over time, and that is not too complex. And then the One Health tool. So that's sort of where we ended up. It's the model that has been used for a lot of the work that is out there, developed at WHO. But just to sort of give you a little bit more on these different models, and there are lots of details that we could get into that I'm not going to in terms of the differences. They are looking at long-term health impacts. So we need the health information, the disease state. We need to know what are the locally relevant interventions that are feasible and effective. And I will just say, that's one place that countries are quite deficient. We found in some of the investment case work we've done that you can go into a country and you can say, what are you doing? But basically what countries are after is, we want to know what the costs and benefits are of better control and management of NCDs. We want to use that for our advocacy.
I think you know that RCTs and randomized trials are good for internal validity. I would argue that they also can be good for external validity, and it's really because of it's a criticism of particular studies that they don't have external validity, not of the approach itself. So let me now turn my attention to one particular case study that we're working on, known as the SMILE trial, which takes place in the land of smiles in Thailand. And that stands for Social and Monetary Incentives for Smoking Cessation at Large Employers. And this is an ongoing cluster randomized controlled trial of work sites in the Bangkok metropolitan area. It's a seven-arm trial where we're testing different types of incentive designs on people's smoking cessation behavior. It's a 3-month intervention with urine testing at 3, 6, and 12 months. The motivation for the SMILE trial has to do with commitment contracts, which originally grew out of public health literature, but have been adopted to some extent by behavioral economists recently. And the idea is that for people who have a self-control problem or a problem with addiction, that you can use binding pre-commitments to try to get people to have more self-control. But our rationale here was to try to increase take-up by combining the deposit contracts with the cash bonus, with the idea that if you add a cash bonus, it's going to entice more people to join. And then we felt like that providing a bonus on top of the deposit contract could substitute for the need for people to commit as much. So our headline finding here is that take-up was high across all groups. It was over 50% for for almost every arm of the intervention, including in our deposit-only group, it was over 50%. The individual bonus, so we didn't really find that the size of the bonus increased take-up. This is not really a strong effect. Here I have arrayed the 100 companies, and then looking at what the take-up was within company across these, you can see there's massive variation. And so this has to do with the institutional factors of how an intervention is really implemented can have a huge impact as well. I'd like to say that RCTs are the gold standard. And a key point for you guys is that evaluations really can't have external validity without internal validity. And this applies especially, I think, to the modelers in the room, that the inputs into your models, it really helps to have something that's a well-identified parameter. And I think using RCTs is a really great way. Having experimentally identified parameters is a great way to do that.
In a lot of cases, we have a predictor, an exposure variable that we're interested in, like income, that we just can't randomize, or that we can, but it's very logistically difficult. It might be unethical. A lot of the tools that we use, like standard regression, OLS analysis, are more apt to identify correlations rather than causal associations. So thankfully, we have something known as instrumental variables analysis that can be used in some situations to deal with this sort of challenge. So again, here we have our predictor income and our outcome, which is child health, and then the unobserved factors that might be confounding this relationship. And what instrumental variables analysis relies on is something we call the instrumental variable, or the instrument, which is exogenous, which is not influenced by these same unobserved factors, and which alters our predictor, alters our predictor and doesn't act on our outcome in any other way. So what is the EITC, in case you're not familiar with it? It's the largest U.S. poverty alleviation program. It involves tax refunds to working families at tax time, with the size of the credit dependent on the earned income of a family and the number of children. So IV analysis relies on certain assumptions. You can't just use it for anything. You can't just pick anything as an instrument. And so I'm going to go through some of the assumptions here. So the first one is that the instrument is actually associated with the predictor. And in this case, we know that to be the case because of tax policy. We know that EITC payment size increases your post-tax income. And this can also be empirically tested in our data set. So another assumption of IV analysis is that there's no alternative pathway linking the instrument and the outcome. And the third assumption is that there's no other confounding between the instrument itself and the outcome. So the data set that I used for this study was the National Longitudinal Survey of Youth, or NLSY. So to summarize the results, in OLS models, we see that larger EITC payments are associated with improved behavioral problems, and in the IV models, we see that there's a causal effect of income on both behavioral problems and the home environment. Again, I wasn't able to present my robustness checks here, but the IV models, the results do hold up in robustness checks and not as much for the OLS models. The effect size here is about 2 to 5% of a standard deviation per $1,000. So, you know, in terms of a clinical trial, that might be thought of as a very small effect size, but this is actually consistent with other studies in the literature of the effects of income on these outcomes.
So this is what happened when you're sort of looking at the years, number of years from joining the World Trade Organization. Okay, so these are all the sort of an average of countries in the year before, the 2 years before, 3 years before, and so on before joining the World Trade Organization. This is what happens right after, and you can see that right at, in the year following joining the World Trade Organization, the portion of GDP that is spent on food imports goes way up. Okay, and so this is what happened to upper income countries, and you can see that sort of in the years prior to joining the WTO, the prevalence of obesity has increased. In low income countries, we have a limited sort of prior information, but it certainly doesn't seem like there's a strong trend. But subsequent to joining the World Trade Organization, there seems to be an upward trend in obesity and overweight. At this stage of this project, the weight of the evidence supports a link between trade liberalization and growing waistlines. But I'll just sort of finish with one last thought that while this seems to be the project at this point looked at a lot of the obesity and overweight. There's also, especially on the sort of low and middle income countries, sort of the other side of the spectrum. And in addition to rising rates of obesity, there's also a parallel decline in rates of stunting and malnutrition.
So typically, the outcome measures of importance of interest in oncology are overall survival and progression-free survival. So here on the graph, the solid lines reflect overall survival curves by treatment, which is the proportion of patients still alive at any point in time. And then here you see also some dashed lines which reflect progression-free survival. So the life expectancy, or the mean survival, or the expected survival, is for each treatment the area under the curve of the solid lines. And the area under the curve on the progression-free survival curves reflects the expected time to disease progression. So given the evidence we have, a set of high-quality randomized trials with censored data, and what we want, long-term life expectancy as well as progression-free survival to calculate our expected qualities, what can we do? What do we need to do in our model? So the first step is since typically in oncology we use the hazard ratio as a relative treatment effect measure, we want to estimate the baseline model properly. And with baseline model, I mean we need to do a meta-analysis of the absolute effect, say the progression-free survival or overall survival curve with a reference treatment. The second step is we want to get an estimate of our relative treatment effects. Then third, as we have seen, our evidence does not have a sufficiently long follow-up. So we both need to extrapolate the absolute effects in step 1, as well as we need to extrapolate the relative treatment effects. So we need to extrapolate the hazard ratios of each treatment versus treatment A. And then finally, we need to bring it all together. So we have our extrapolated absolute curve with treatment A, we have our extrapolated hazard ratios. We need to combine these to get an absolute estimate, meaning an expected PFS and an expected OS curve for all our treatments of interest. So to summarize, evidence synthesis plays a major role in cost effectiveness modeling or decision analytic modeling. We want to have proper estimates for the baseline model, absolute effect with the reference treatment. We also want to use proper estimates for the relative treatment effect versus the reference. And the relative treatment effects versus the reference, we like to use that to base it on randomized controlled trials, and we can use network meta-analysis techniques. We can use assumptions of constant treatment effects over time, proportional hazards, constant hazard ratios, or time-varying approaches. And the key thing is, in all these kind of economic models, if we need to extrapolate, make sure that you really test the assumptions of your model, in particular proportional hazards, because it can result in dramatically biased estimates.
So I thought I would frame my talk today with rheumatoid arthritis. And that's because it's our most prevalent inflammatory rheumatic disease. It affects 1.3 million people in the United States, so it's not rare. The onset of this disease is during the prime of working life, and 1/3 of people will be disabled within 5 years without treatment. So really a devastating diagnosis and an onerous course. So my conclusions: specialty RA drug prices are rising sharply each year despite competition. High prices are being passed to patients. They have very high coinsurance for Medicare Part D. Some people are accessing this through their medical benefit and actually trying to address that complexity where we're covering things in 2 different programs that are not necessarily sort of unified in their approach to payment is something that is really an Achilles heel of payment reform. And I think biosimilars will eventually reduce costs, but they're unlikely to produce the substantial savings that we see in the generic market for small molecule drugs.
The good news is that we've developed many, many new therapies, devices, drugs, and procedures over the past 40 or 50 years, but they almost always tend to be very expensive, new things for heart disease. Part of this dynamic led to the development of clinical practice guidelines. And this is a joint effort of the American College of Cardiology and the American Heart Association. And they got started back in the 80s when there was concern from the predecessor of CMS about overuse of and inappropriate use of pacemakers. And they asked about getting together some guidance for physicians about when to use these. And the way it works is that there's a staff. They help people get together in developing this. They have a writing group, and I've been on a few of these. They're volunteer experts. Nobody gets paid for doing this. It comes out of your time. They do have very strict concerns about conflicts of interest to make sure that nobody's overly influenced by this. And the most important thing about it is that they've gone from being opinion-based to being evidence-based. And they grade the level of evidence, in fact. And I think you saw Ron show that little hill with the kind of evidence. We still pay a lot of attention to that, and the king of the hill being the trials. What's been absent from this entire framework, though, was any sense of cost or cost effectiveness. They're always been aimed at optimizing clinical care and outcomes and not paying any attention to the economic part. And you can see a quote that traditionally resource use and value have not been explicitly excluded from any consideration, although they're implicitly considered. And these were the proposed level of value criteria. So a high value, better outcomes at lower cost, or an incremental cost effectiveness ratio of less than $50,000 per quality gain. intermediate 50 to 150, and low value above 150. So let me just wrap up by saying that I think that these clinical guidelines are highly regarded and very helpful to doctors. They're used in practices. They're actually used to even set performance measures and so on. We are trying to get value statements into these guidelines, but it's very challenging still. We don't have good evidence to back up all the recommendations that are out there, and we need high-quality evidence that everybody can trust before we can go ahead and put this in.
So I want to start off with where this came from. As many know, back in 1996, the Health and Human Services commissioned a book which is called the Gold Book. And really what it was a panel which looked at the cost factors in health and medicine. The second panel has been recently published their findings. So there was a lot of different institutions affiliated with this panel and a lot of different perspectives that came into it. We actually have 4 chapters that are brand new, one focusing specifically on the reference case, another one targeting decision modeling and its use in cost-effectiveness analysis, another focusing on evidence synthesis, which again was something that wasn't covered explicitly in the original book, and then a whole chapter focusing on the ethical considerations of both conducting and implementing cost-effectiveness analysis. So since the original panel, there's been some experiences that we could actually look at and pull and try to incorporate into these new recommendations. Many of the cost-effectiveness analyses that have been done since 1996 do not actually use the societal perspective, even though that was the recommendation. Even the many that actually say they're using the societal perspective are not actually truly representing what is, at least how we were defining it, a true societal perspective. Our recommendation actually for the reference case is changing the original panel's recommendations, and we now actually are requiring or asking that all studies represent a reference case based on 2 different perspectives. One that we're calling the healthcare or the health sector perspective, and then a second reference case based on the societal perspective. The second thing that we've done that's quite different is we have a recommendation for what we're calling an impact inventory table. And so what this really is a table that's listing all the health and non-health impacts of a given intervention. So we have things divided up into whether they are in the health sector, and we actually divide that into both the formal and informal healthcare sector. And then at the bottom are these non-healthcare sectors. And so for these are examples, the productivity, consumption, social services, legal or criminal justice sector, the educational sector, housing, environment, and other. And so the next column is really the different types of impacts. And so here, the easiest thing to think about is for the health sector, we have the health outcomes or effects, and then we also have the medical costs. For the other sectors at the bottom, I'll go a few slides, kind of go through some examples there, but we have, for example, in the education sector, maybe the impact of the intervention on educational achievement of the population or things like that. So looking at different types of impact that you could have for these different sectors. We then have a checklist where you actually, we want the decision analyst or the cost-effectiveness analysis to actually indicate which ones are included or excluded in their specific analysis. The next column is really the different types of impacts. And so here, the easiest thing to think about is for the health sector, we have the health outcomes or effects, and then we also have the medical costs. For the other sectors at the bottom, I'll go a few slides, kind of go through some examples there, but we have, for example, in the education sector, maybe the impact of the intervention on educational achievement of the population or things like that. So looking at different types of impact that you could have for these different sectors. We then have a checklist where you actually, we want the decision analyst or the cost-effectiveness analysis to actually indicate which ones are included or excluded in their specific analysis. In terms of valuing costs, the societal reference case really takes in a lot of different types of costs. So, here some of the key modeling recommendations is that your initial conceptualization should really be independent of the data identification phase. You should really be thinking about what the natural history of the disease is, what are the different interventions that you're caring about, what is the different outcomes that you're looking at, all the different components of cost-effectiveness analysis, making it very clear and as much as we can, making it transparent to the reader. We have a reporting checklist that we include, and this tries to give for a decision analyst while they're doing, or a cost-effectiveness analysis while they're doing a model, but really understanding that anything that we can be doing to allow models to be more freely shared might ideally increase their transparency, they're transferable to other decision-making contexts, and then potentially making a bigger difference into practice and policy. And going forward, one of the areas that we're trying to push is really kind of how we can increase sharing of models and data, how to actually do that, taking into account balancing both the kind of technical difficulties with that, as well as the intellectual, trying to deal with kind of the intellectual property differences with sharing models. And then the final area is really just some of the ethical issues. And this was a chapter that was new to the book, and it was really trying to look at what are the issues related to both conducting cost-effectiveness analysis and then also actually implementing them.
Well, I'm going to talk about some of the challenges in future research. So one area was the role of economic theory versus practical decision making. So many of us, I'm a physician, do cost-effectiveness analyses and have sort of a pragmatic goals in mind, though the health economists really approached this from a much more theoretical foundation. And there were differences, of course. For those of you who have done cost-effectiveness analyses, you'll recognize that the notion behind a reference case is that you do things in a similar way, so that an analysis that I do about implantable defibrillators with Jillian or Mark could be compared to an analysis somebody else does about breast cancer screening. But part of the rationale for a reference case is that I can compare my analysis to yours, and maybe we can compare an analysis done now to one done a few years ago. But the changes that we made in the reference case are substantial enough that we recognize that it really was going to impact the ability of comparability over time looking backwards. A big issue, and maybe in the Q&A we can talk about this, that we worried about was practitioner burden, publication challenges. This is why I ask for our colleagues here who are editors what they think about this, and then the accessibility of the findings. Really makes very explicit that you might have situations in which there are spillover effects to other healthcare sectors, education, criminal justice, etc., and that's very rarely included in cost-effectiveness analyses. So modeling is going to have to be used in most analyses, and the new chapter on that was recognition of that. And then you can use these different models to compare and contrast. They often have different structures and different assumptions. And so how best to use that, how to reconcile those when the models don't all agree, is an area that is ripe for further research. Related to this is how reproducible is the modeling. If another group did it as an independent replication, would they get the same kind of answer? One of the things Jillian didn't mention is that one of the new recommendations is that people publish or develop and make available a protocol for the cost-effectiveness analysis prospectively. Then how to integrate cost-effectiveness into broader decision-making frameworks. So some of the people, Murray Cron in Canada, were people, and Mark Sculfer from the UK, people who really use these cost-effectiveness analyses in technology adoption decision-making. Also the VA, for example, which is committed to treat everyone with hepatitis C, probably will spend between 10 and 15 billion dollars on treatments for hepatitis C. And this is a huge issue. So you can have something that is cost-effective or good value, but still in aggregate is extraordinarily expensive. And then how do you use that in decision-making? How do you integrate those things? So with that, I think I'm going to wrap it up with just one more thanks to Jillian for her extraordinary leadership in developing these recommendations.
So first of all, what is integrated care? And WHO has a very long and complicated definition of this. And truthfully, I've never, ever seen a system in my life that meets that definition. This is a little bit toned down, but it basically talks about the continuum of preventive and curative services across different levels of the healthcare system and over time. The simpler definition that I learned in my first year at Kaiser was we aim to provide the right care at the right place at the right time. What do we know about integrated care in low and middle income countries? And also, can we categorize this evidence based on the triple aim? In the triple aim framework, which is the IHI framework, that head of the pin is balancing population health, the experience of healthcare, and per capita cost. So when we looked at the literature, what we found is that even though we sifted through a lot of studies that could have hit on these different aspects of integrated care, there were only about 23 that met our criteria. And all of them focus on a few limited levers of integrated care. So not surprisingly, the most common lever is human resources, either through kind of a primary care coordination role or team-based care or task shifting. And we did not include all task shifting because there's lots of examples of task shifting in low and middle income countries. What we were particularly looking at is if it is task shifting to provide better management of chronic diseases, then it comes under this, our review, otherwise it does not. I will say that all of the studies had a positive impact. So it was interesting that of 23 studies, we found that all of them showed some kind of positive impact from integrated care. The conclusions are integrated care examples are really in their infancy, but policymakers in countries are interested because they're grappling with trying to solve their already high disease burden of infectious diseases. They've got broken healthcare systems. They're trying to move toward universal health coverage with all of the NCD complexities and cost pressures. And so new models are possible. And I think they might be more possible in developing countries than in the rich world because we really have lots of broken systems, not very good infrastructure, not very entrenched stakeholders. So there's an opportunity to really do some innovations. There's also a limited number of specialists. So there's an opportunity to go and use paraprofessionals, use teams to provide care that we cannot do in the wealthy world.
So this is a telephone survey that Summers and Epstein performed in November and December of last year. And it's 3,000 folks in the states of Arkansas, Kentucky, Louisiana, and Texas. And the question was, do you think the Affordable Care Act helped you or hurt you? So it turns out that the most powerful predictor, whether you thought the ACA was helpful or hurtful, was whether the state expanded Medicaid. So what is my prediction for Medicaid expansion? I think that they are probably going to have to keep it because it's going to be hard to get rid of. But it will probably be rejigged so that states will have more flexibility on using market-based solutions to Medicaid expansion, as 7 states already have. The bigger threat to Medicaid, then, is not the repeal of the Medicaid expansion, but what they're planning to do with Medicaid itself. And the idea here is block granting Medicaid, which is it's a fixed sum of money that goes to the states. Why will it pass? Because you don't need a Senate majority. The budget reconciliation process can only address things that affect the budget, as the name suggests. So a lot of things about the ACA can be addressed through it. What cannot go away are more structural things, like, we have minimum requirements for insurance plans. The preventive services have to be covered. The actuarial stuff around how much you can charge for insurance. That stuff requires replacement, and replacements can be filibustered. What does that mean? It means we're looking at a partial repeal. And that is probably worse than repeal and replace. I'm going to summarize what I think are 5 major implications for our work. First, what are the kinds of questions we should be asking? I would insist that this is a time to ask strategic questions that we answer in a timely manner. Asking questions about drug pricing or health policy or the impacts of Medicaid expansion are probably more important than this nuanced biomarker that is going to predict, 30-year mortality. And so trying to figure out how do we make dissemination an important endpoint. We figure out the language that people are using, whether it's on Twitter or on other forms of social media, so that we can communicate what the big ideas are. Finally, I told you that I didn't think this is a time where we can sit back and relax. We can do very good work, but this is the time where you have to engage yourself in advocacy. There are lots of different options. You pick one. The economists who evaluated, whose work I presented at the very start, said that Republicans voted to repeal the most important parts of Obamacare in January of this year, but they did that knowing that President Obama would veto that measure. It would be a different vote knowing that President number 45 would sign it. So they're thinking that perhaps the behavior of our folks in Congress will change knowing that now they're responsible for their actions. For me, however, the events of the last 32,200 minutes that this president has been in power, every minute of those makes me less hopeful.
The fundamental maxim of utilitarianism can be summarized very easily. It is to maximize human happiness, human well-being, utility. So in the context of global health, there are at least three implications of utilitarianism that fall directly out of these principles. The first is really a restatement of what I just said, that within healthcare provision, we want to allocate resources in a way that's consistent with maximizing benefit. Global health and public health, the word global in global health and public in public health pertains to large populations and thus lends itself to the more abstract modes of reasoning that are consistent with utilitarian calculations. And therefore, utilitarian calculations and where cost effectiveness leads is the right place to start in thinking about resource allocation.